It is now my pleasure to welcome to the stage Dr. Haejin In. She is a surgical oncologist and associate professor of surgery and associate professor of health, behavior, and policy at Rutgers. She's also the chief diversity officer, as well, and associate director of DEI at the Rutgers Cancer Institute. She specializes in the surgical management of upper GI cancers and peritoneal surface malignancies and focuses her research on identifying optimal strategies for early cancer detection, as well as screening for gastric cancer in the United States and quality care metrics. So it's our pleasure to welcome her to the stage.
Great, thank you so much. So it's really nice being here, and I love the fact that we're together thinking all together about gastric cancer, because when I first started my research, I really wasn't able to find a group of people to work with, and so it has been a great journey. And this is one of the ideas that I was able to develop throughout the years, and I will take you on the journey of how I came about this, how we've been doing it, and some preliminary results. I went back home last night and I realized that people were trying to do very similar things right now. So I ended up adding in a lot of slides, more about sort of the nitty-gritty details of how we've been doing it, and with the hope that other people could, learn from my mistakes or, the pain that I've had to go through to do this. So we called this study the pilot study of stomach cancer early detection and prevention with endoscopy. I called it Pilot Screen. And, I don't need to do an introduction, but, gastric cancer is serious. We don't have screening. We need screening. So I'm not the only person who thought about adding an opportunistic EGD to a colonoscopy situation. There are studies out of Singapore, Germany, and other countries that have that have looked at adding on EGD when the person is getting screening colonoscopy, and have found that, you can detect precancerous lesions. Cost-effective analysis done by Dr. Shah and others have also shown that a one-time EGD at the colonoscopy could be cost-effective. So this is the proposal that I submitted to our pilot program at our cancer center. This is one of the first pilot grants that I wrote when I got to my new institution, and it was a good way for me to just kind of get restarted in my new institution. I proposed that, we were going to ask people to do this with the aim that we wanted to determine the feasibility and safety of EGD at the time of colonoscopy, document the rate of precancer and cancerous lesions, examine the precursors of uptake for EGD, and of course, this was a good opportunity to collect some samples so that we could do some exploratory aims like biomarker development. So the study design, we recruited individuals age 45 to 80 years old who were scheduled for colonoscopy at our university hospital. I wanted a sample size of 50 participants divided up into half high risk and half low risk, with the definition of high risk being, of all the presentations you heard yesterday, somebody having a family history, somebody being of Black, Hispanic, or Asian Pacific Islander ethnicity, or first-generation immigrants from high-risk regions. Inclusion criteria included, the age. They could not have undergone an EGD. They could not have had a planned EGD, nor should they have had an EGD in the last 5 years. And we wanted to collect, blood, urine, stool, saliva, and then also get targeted biopsy samples during the EGD. We also did some surveys. And so, we started off with just screening people first through the EMR system. Then we would contact people for eligibility and interest, and then go on. This is the endoscopy sheet that we developed. We developed a collection sheet for the endoscopist to use. So we asked that they do it according to the Sydney protocol. This was when I discovered that our gastroenterologists actually are not doing biopsies often. As a matter of fact, they either don't do biopsies or they cherry pick. So I actually had to insist that they do the Sydney protocol. And I also asked them to document any findings that they found when they looked with the endoscopy. Then the specimens would get over to pathology, where we ask them to do, but the pathologists that work with us to look at each of the specimens and give us a grade, normal, mild, moderate, marked for Helicobacter pylori, neutrophils, monocells, atrophy, as well as intestinal metaplasia. And we did it for 5 different locations. We did not put them all together in 2 jars. We actually did 5 different jars. And that's how we asked them to do it. And then our team would then put it all together, actually like stage it, stage the numeric stage, and then figure out if it was complete or incomplete, limited or extensive. So this is the study timeline of what we went through so far. So the grant prep and submission started early in the year, so early 2022. Because I'm a surgeon, I had to find a gastroenterologist to work with, so had to ask around to see who would be willing to work with me. And then the cost negotiation with our hospital about how much they were going to charge for the EGD took a while as well. I did get the grant. This was in June. We submitted the IRB. IRB got approved, and it really took a long time before we were able to get the first participant. After we got a couple of participants, we realized that we needed to modify some protocols. We added on urine collection. We originally had done the age to 50, but with the colonoscopy guidelines, we decided to change it to 45. We added some translations, and most importantly, I was finally able to get a research coordinator to work with me. So that started picking up things. And so our 10th participant was a few months after that. We realized that one person doing this was really not enough, so we were able to get a student to also help. And so we hired a student to help out, and that's really when we started to pick up a little bit more. We had to ask another gastroenterologist to be a part of it. And so on. So we really had, a lot of learning to do. We had a lot of missteps along the way. Not anything big, but just like how to move things forward was really what we needed to learn. I know that people had a lot of questions about cost yesterday about EGD, so I added this slide. So this is how my budget was structured. So I had a 25% FTE for a research coordinator, EGD costs, specimen processing, pathologic review, and then some minor things, shared resources for setting up REDCap, as well as biostatistics. The budget was mainly broken down because we needed to pay for biopsy, like storage, actually doing the H&E biopsies, all of that. And in particular, I know that everybody's curious about this one. How did I negotiate the EGD cost? So started off with the CPT code for EGD with biopsy. Medicare pays $980, and what I learned is that our university charges 1.5% or 1.5 for research. And then from then on was the negotiation. So basically I argued, well, you're doing the EGD at the time of the colonoscopy. If you went out to Medicare and got paid, you would only be getting 50% anyway. So why are you charging me for both? So after some negotiation, they agreed to it. And so they gave me a 50% discount of the research charge. I'm like, couldn't you have done that with the original Medicare? But they're like, no, we're going to do it with the research cost. So I was able to get it down to $612, and that's how the budget was formed. I learned that we need more than one person. It wasn't so much about the time that they were utilizing. It was more that you just needed people, like people to sort of have the energy to keep going. As well as sometimes, one person's not there and such. So anyway, adding on a part-time student was really beneficial. We also learned that the $600 that we had negotiated really was the EGD itself, and they were going to charge us separately for professional billing. So that was an unseen for cost. Pathology, because we're working with the biobank, we did need to pay for it, but the review itself and the biostatistics, we ended up really not having to really pay for it. Our pathologist just wanted to work with us, and that was all fine. So sort of all balanced out. Okay, so this is now the results. So far we've enrolled 30 patients, of which 17 were high risk and 13 were low risk. Male-female split was actually quite even. This was not intentional, but somehow it happened. 254 patients were first, getting colonoscopy at that time, which got an EMR review. 51 patients were removed because they already got an EMR. 214 patients underwent chart review and then were called again. 94 patients we couldn't contact. And so of the 120 patients that were contacted, they were actually asked and such. And so in the end, we were able to get to 30 patients that we enrolled, and with that 25% being enrolled. 58 patients were, had declared when we contacted them that they were not interested. So we did collect why were they not interested. Patients, the majority of patients, it was because they were fearing the additional procedure, was what they said. Some people just said, no time, I'm concerned about the biopsies. The rescheduling and the canceling of, just kind of wanting to go on with their lives was another reason. And then just, people who said they didn't want to do research. There was a little bit fear of discomfort, privacy concerns as well. But you could see that there is a difference between high risk and low risk, like how the percentage of people that decided to refuse. The low risk people did have a slightly higher refusal rate at 57%, while as the high risk patients had a little bit lower, but still surprisingly quite high. 43% did not want to participate in the study. So age 56 was their median. We had a distribution of race, ethnicities, some comorbidities. And so the pathology reports show that 50% of high-risk patients and 45% of patients in the low-risk group had Helicobacter pylori positivity. Atrophy, 25% versus 9%. Intestinal metaplasia, 12% versus 18%, and no patients had dysplasia. When I did it as sort of a combo, and if a patient, percent of patients that had any of the findings, Helicobacter pylori, atrophic gastritis, intestinal metaplasia, or dysplasia, you could see that the high-risk population had a much higher rate, so 81% versus 45%. And then if you took out the Helicobacter pylori part and just the findings, it was 43% and 18%. Now, obviously, these are very small numbers. We're only dealing with 30 patients, but it was interesting. We also did surveys about how much they knew about stomach cancer, what they thought were the barriers, the benefits. We found, so this knowledgeable, moderately knowledgeable, was based on a bunch of questions that we asked about, do you think that this is a risk factor, to see whether or not they understood it. We found that people were generally somewhat okay. I think more than half of the people got like half right. And then about benefits, knowledge about gastric screening benefits, questions like cancer can be found early, treatments aren't bad, are not so bad if you undergo screening. The best way to find small cancers is to undergo screening. And you'll see that it's not great, but at the same time, it's not as terrible as I would have thought sometimes. 58%, 70%, 84%, something like that. Perception of seriousness. How serious is gastric cancer? Everybody thought that gastric cancer was terrible. And have you ever talked about your personal, risk? And that we only found one person who had said, oh yeah, I've talked to my doctor about this, or my doctor has talked to me about this. Gastric cancer and barriers. Not a lot of people actually talked about a lot of barriers. Is it embarrassing? Is screening embarrassing? I don't is it going to take too much time? Is it going to be painful? Too much anesthesia? All of them, the numbers were quite low. Not a lot of people expressed concerns about doing EGD or adding on EGD. We also had a dietary survey, and so we saw that, we asked about pickled food consumption, alcohol, adding salt to your food, spicy food, vegetable intake. And the interesting thing you'll notice here is that all of the high risk had slightly higher rates than the lower risk group. Lifestyle-wise, exercise, activities interrupting bowel. This is like worded really weird, but it is basically, are your bowel movements interrupting like your lifestyle? And surprisingly, it was a little higher in the high-risk group. And then healthcare access. Do you have transportation to get to healthcare? And you'll notice that 27% of the high-risk group reported that they did have access issues getting to healthcare, while as 9% or one patient said that they had some issues. We asked about satisfaction. So this was on the 22 patients who answered the survey after they were done. We contacted them within a week after they were done. Just putting it all together, everybody was satisfied or very satisfied. Everybody thought that it was very easy to do. They 100% said that they would do the EGD at the same time as screening colonoscopy. This was interesting. 62% stated that the addition of EGD would make me want to get screening more than colonoscopy alone. Willingness to do in the future, everybody was very willing. They would all recommend it to their family. They found it pretty comfortable. Only one patient said it was uncomfortable. And then none of the people reported that it interfered with priorities. And everybody basically found it completely acceptable or acceptable. So that was the main result. And then I just wanted to throw in one interesting thing that we observed along the way. So this is the clinical pathology report. So this, we also looked at, what they actually had in EPIC and compared it to what we found in our study. And interestingly, we found only one patient had intestinal metaplasia reported in their clinical pathology report, as opposed to 4 that we found in our study. For Helicobacter pylori, we found, the EMR would suggest that 9 patients had Helicobacter pylori positivity, while as in our study, we found 13. I sort of try to make this to try to sort of look at it and figure it out. So once again, 1 patient had EMR positive intestinal metaplasia, while as our study found 4. And it looks like the person who actually had the clinically reported positivity for intestinal metaplasia did have intestinal metaplasia sort of throughout their stomach, mild grade for the antrum in the lesser and the greater, and then in the corpus a little higher. In the incisura, it was graded as 3. And so concluded as an OGM stage 3, complete type, extensive. And then for the 3 that didn't show up in the clinical notes, we found that it was, very mild, just in the antrum really, and then the last one where it was OGM stage 2. And then in the last few minutes, I just wanted to talk about, the great event that the NCI put together that I think most of us were there for, which was a think tank on advancing gastric cancer prevention. And it was an amazing event. The NCI really did it for the first time to maybe hopefully signal that they're now interested in gastric cancer and especially early detection and prevention. Many of us were there, and one of the things that came out of it was that we were sort of shepherded, of course, by the great connector, Constanza Camargo over there, into people who were interested in very similar things, and to try to get us to do research together. And one of the things that came out of that was that we came together to put in a DoD grant. And for those of you who don't know, the DoD only allows you to submit for certain cancer types in their grants. And one of them is stomach cancer. And this I know because one of the stomach cancer advocacy sites, Debbie's Dream, was one of the groups that actually petitioned the government to put this in here. So anyway, stomach cancer was in there, and a bunch of us came together to basically propose a larger study doing the same thing that I was trying to pilot. And so with this, we have 5 institutions together with people that are all sitting here to enroll 600 participants. And the aims are pretty similar, but the biggest thing that we're going to be able to get out of it is the thing that we kept on talking about yesterday, the thing that we don't have, which is understanding the prevalence of gastric cancer precursors in asymptomatic patients. Because for this study, we are going to be enrolling patients who otherwise don't need EGDs, or in American criteria at least. So in summary, EGD at the time of colonoscopy may be an effective way to screen people. It seems to be quite feasible. Patients were very satisfied. Patients were surprisingly fairly knowledgeable about gastric cancers and the benefits of screening and reported low barriers. And it was the same for both the low-risk and the high-risk groups. But the high-risk groups definitely did report more bad behaviors and difficulty with access, likely implying, basically probably reflecting the fact that they're immigrant populations as well as lower socioeconomic status. So thank you.